Respected senior professionals, especially Dr. P.V. Ramakrishna Garu, senior most pulmonologist of the town. So today's topic will be on the obstructive airway disease. So in the next few minutes, I would like to talk on obstructive airway disease and its subspecialties like chronic bronchitis, bronchiolitis, emphysema, bronchiectasis, bronchial asthma, and diagnostic measures and the management of these diseases, and the role of the N-acetylcysteine, a critical appraisal in the OAD obstructive airways disease management. See, as you all know that OAD means airflow limitation. It involves the different mechanisms and parts of the respiratory tree. If you see the chronic bronchitis, it is because of the hypersecretory. Chronic bronchiolitis because of the obstructive nature of airflow limitation. And in emphysema, there will be the destruction of the SNI leads to the airflow limitation. So most important pathophysiology of all these things and risk factor is obviously the cigarette smoking. It frequently coexists, but two clinical syndromes, blue blotters and the pink puffers. So since our undergraduate days now, so we all thought as blue blotters and the pink puffers are very, very important subsets of our obstructive airway diseases. So blue blotters, mostly the chronic bronchitis. Here the POT is reduced and PCOT is elevated. There will be the hypoventilation and always associated with the pulmonary hypertension and leads to the carpulmonary. So the right heart failure because of these pulmonary hypertension and the respiratory diseases. Here, mostly the oxygen therapy kills the patient in the blue blotters. Whereas the pink puffers, the main reason is the emphysema. Here the PO2 and the PCO2 are the normal, whereas in the blue blotters, the PO2 is reduced but PCO2 will be elevated. Here it is hyperventilation, whereas in the blue blotters is hypoventilation. Here the pulmonary hypertension, even the normal blood pressure, they are the normal, and heart is also normal. Very rarely they go to the carpulmonales. Here oxygen relieves the dyspnea. So these all diseases are particularly more common in those people who are genetically predisposed. So the reasons to cause the COPD are some allergens, irritants like smoking, some infections like chronic infections or viral infections or bacterial infections or parasitic infections. Small airway abnormalities leads to the chronic obstructive bronchitis, destruction of the valves, that is emphysema, and severe bronchospasm leads to the asthma. So finally, the diseases are the asthmatics, emphysematis, and COPD or chronic obstructive bronchitis, so leads to the COPDs. Lung disease that makes it hard to breathe in obstructive airway disease. There will be increased airway resistance, the flow will be reduced. The first symptoms can be so mild that people mistakenly think that they are getting old. Tends to get worse for a period, but catching it early along with the good care can help many people stay active and may slow the disease. See, otherwise if you don't recognize this disease at an early time, so what will happen to their lungs? So obviously they are going to worse and they are almost crippled and they can't do anything without much breathlessness. So the obstructive airway disease are early to recognition, early to diagnosis is very, very important to give them a good quality of the life and to reduce the morbidity and mortality also. It is all characterized by the airway obstruction that is worse with the expiration. More force is required to expire a given volume of the air, or emptying of the lungs is slowed, or the both. So expiration and also the inspiration and emptying of the lungs is also slowed in obstructive pulmonary disease. So here all the examples you know that. In emphysema, there will be the damages the tiny air sacs in the lungs. Air sacs can't expand and contract properly. Alveoli enlarge, which trap the stale air, and very few capillaries, and great trouble exhaling. So if you see the picture, the normal picture and the abnormal picture, the first one is the abnormal, the lower one is the normal. In the normal bronchioles and the alveoli, you will have a very good capillaries, and the alveoli are not enlarged, and there is no mucus. But in emphysema, there will be the mucus in the bronchioles, alveoli are enlarged and a thin wall, and there will be very, very few capillaries leads to the emphysema. See, small airway disease, the airways less than the 2 millimeters, they are the small bronchi, mostly the proximal bronchioles. Bronchular goblet cell metaplasia, there is a loss of the Clara cells, loss of the protease inhibitor. The celiac cells will be there, cilia will be disturbed. So there won't be any protection to the internal and the small bronchi, so that all the infections will go there, and there will be the more and more mucus and more plug formation and the blocks. Chronic inflammation and the fibrosis, the stenosis will appear, and there will be the hypoxic pulmonary vasoconstriction leads to the pulmonary hypertension, and then cor pulmonale and compensatory polycythemia. So these are all the diseases which are occurring because of our small airways diseases. Morphological types according to the part of the acinus affected in emphysema is the centriacinal, mostly the cigarettes induced, and upper lobes are involved here. Panacinal, here the alpha-1 antitrypsin deficiency, mostly the lower lobes, and paraseptal, either septal or subpleural. See the picture here, it's the centrilobular emphysema on the left side. On the right side, you will have the septal emphysema. See, these are all the large bullae. It's a large solitary bullae. These may grow large enough to cause the respiratory failure by compressing the adjacent normal lung. So the corrective bullectomy or the lung reduction may return the pulmonary function to the normal. See, this is excised bullae. So this is the panacinar emphysema. So entire lung is involved here. So the pathogenesis of the emphysema, there will be the proteases and the antiproteases. So the protease is also called as elastase. Here the neutrophils and the macrophages, they are the source of the elastase. They are increased in the smokers, in the chronic infections and inflammatory disorders. Smoking stimulates the release and enhances the activity of these elastases. And oxidants in the cigarette smoke inhibit the native alpha-1 antitrypsin activity. This alpha-1 AT deficiency, there will be the unopposed elastase activity. And these are the different protease inhibitor locuses are there. So this is the chronic bronchitis. Here the narrowed airway. There will be the inflamed lining of the bronchial tube. And here I told you the cilia will be damaged. So with the chronic bronchitis, the lining may stay inflamed and the cilia may not function. So a lot of infections will go inside. So it is called is nagging in cough with the plenty of the mucus. There will be the swollen wall of the small airways. There will be the constant oozing of the mucus and the scarring. The trapped mucus block the airways, airflow, and become a breeding ground for the germs. So a lot of the infections here, both gram-positive, gram-negative organisms will stay there and flourish like anything. So the persistent or the recurrent excess of the secretion in the bronchial tree on most days for at least 3 months in the year over the 2 years to call it as a chronic bronchitis. Not a single attack in a year or the 2 attacks. So it should be at least for 3 months in a year for over 2 years. That is the chronic bronchitis. It is the middle-aged, mostly the elderly population, males more than the females. There will be the mucoid sputum, and if you send it for the sputum culture and sensitivity, mostly the influenza, the streptococcus pneumonia, etc. And the smoke, air pollution, dust exposure. So these are the major irritants. And the bronchi will be filled with the mucus and the pus. There will be the enlargement of the submucosal glands. So this is called as a Reed index. Shift to the pure mucus from the mixed seromucinous types. And there will be the increase in numbers of the goblet cells in the epithelium. So at the expense of the ciliated cells and the Clara cells. So the ciliated cells and the Clara cells are the protective cells. So they will be replaced by the goblet cells. They are the pathological cells. Leads to the lot of the infections. So this is an acute and the chronic bronchitis. A lot of the plug and the mucus and the loss of the cilia and more inflammatory cells, macrophages, polymorphs. Here the loss of the airway tapering in the chronic bronchitis. So in asthmatics, there will be the bronchiolar constriction, mucus hypersecretion, and there will be the inflammatory swelling. So here if you see the vessel, bronchi, so there will be the diffuse changes will be there, and there will be the narrowing. This is characterized by the hyperreactive airways leading to the episodic, reversible bronchoconstriction, and there will be the increased responsiveness of the tracheobronchial tree to the various stimuli. So almost it is always an episodic and a reversible bronchoconstriction. There will be the extrinsic or atopic allergic, so allergic to the allogenous, exogenous substances. And there some people will be having the intrinsic or idiosyncratic or non-atopic. There will be the no exogenous factors identified. So now we can get the IgE estimation. Here in atopic or allergic on individuals, this IgE usually should be the adults normal less than 100, but some people may have 500, 1000, more than the 1000 also. That shows the atopic allergy. So it's a very common in the childhood, more in the males, less severe as age, but 30% symptoms as adults. Associated with eczema and rhinitis, the most of these people will have the running nose and also some eczema, and there will be the environmental triggers, and it's an IgE mediated hypersensitivity reaction. Non-atopic asthma, it's the adult onset, a chronic one, tending to worsen with the age, so more in the elderly individuals. It's triggered by the respiratory tract infections, especially the viral. Family history is uncommon, whereas in atopic asthma, the family history will be there. Serum here, the serum IgE is the normal, whereas in the atopic asthma, earlier one, it will be very much abnormal IgE. And here the virus-induced inflammation may lower the threshold of the receptors to the irritants. So these are all the Churchman spiral or seriola bodies. So they are all seen in the bronchial asthmatics. Here the uniferinflated lungs in the status asthmaticus. See the lung size is much enlarged. Here the more of the mucus plugs in the status asthmaticus. See the normal lung and asthmatic lung and the emphysematous lung. So common symptoms here, the inside the lungs, the clogging of the airways and the damage, the tiny balloon-like sacs, alveoli. There is the shortness of the breath. It's a very, very common in this population. Everyday activities it disturbs. Lot of the wheeze, expiratory wheeze, and there is the tightness in the chest, constant cough, and cough with the sputum production, mostly the mucus. And if it also is the secondary infection, you will have a sputum. Sputum will be foul smell. Sputum is also will be a possibility there, and always feeling tired, asthenia, and frequent colds or the flu in atopic asthmatics. And some people, it's very difficult to walk, cook, or clean the house or even the bath in the advanced stages. And there will be excess mucus, and the feeling short of the breath may worsen that. There will be swollen legs or the feet from the fluid buildup because of the carpal nail. So that is the right heart failure. And weight loss, less muscle strength and endurance because of the hypoxia and hypercapnia. Headaches in the morning, maybe because of the hypertension, systemic hypertension or pulmonary hypertension. Blue or the gray lips or the fingernails, that is our cyanosis due to the low oxygen levels, hypoxia. See, there is a multifactorial pathophysiology. Fundamental one is increased resistance to the airflow as a result of the caliber reduction of the conducting airways. So the most important pathophysiology here is the increased resistance to the airflow. So there will be low air entering into the lungs. Why there is increased resistance? That caused by obstruction within the lumen. It could be due to the increased secretions as seen in the asthmatics and the chronic bronchitis. So the lumen obstruction because of these secretions. So that could be the reason for the increased resistance to the airflow. And another cause is the airway wall thickening and airway narrowing can result from the inflammation seen in both asthmatics and chronic bronchitis. So here not only the lumen obstruction because of the secretions, the wall itself will become thickened because of the chronic inflammation. And then there will be the loss of the surrounding supporting structure with the expiratory airway collapse resulting from the destruction of the lung elastic tissue. So you all know that lung bronchi or bronchioles or alveoli, they are the very elastic one. So because of the loss of this structure, so there will be the destruction of this elastic tissue. So leads to the toughening or the roughening of these tissues. So definitely leads to the decreased airflow. So it could be because of the within the lumen obstruction with the secretions or the wall thickening because of the inflammation or because of the destruction of the lung elastic tissue leads to the increased resistance. So this is the pathophysiology. So in one word, there will be the inflammation, hypertrophy because of these cells, decrease of the ciliary cells, this already told you the protective cells, and their activity leading to an accelerated loss of the elasticity of the lung tissue. So due to this, more prone to the collapse, thus leading to the emphysema in almost all cases. So there will be the decrease in the space available for the gas exchange, and there will be increased secretions in the lower respiratory tract, unable to move out due to the low ciliated cells activity. So now coming to the NAC, there will be the improved FEV1, less dyspnea, lower radiation of the bacteria, and lower exacerbation rate will be seen with these NACs. See, if you see here, the first thing one is the forced expiratory volume 1 will be the reduction will start. But those most people they will be asymptomatic at this juncture. So the finally when the FEV1 is very much reduced, so slowly the dyspnea will appear, and finally they need either short-acting bronchodilators or the long-acting bronchodilators or the inhalations or oxygen, and finally admissions and respiratory failure and the death. So that's how it happens. So when you think that it could be because of the bronchitis or bronchiectasis, etc. So pulmonary function test and FEV1, you have to assess it whether it is reduced. So you should give a good warning sign to you that this could be a case of the COPD or the carpulmonal, etc. See, at risk, nothing will be there, and symptomatic again the FEV1 will be reduced. In exacerbations, all these things will be there, and finally the people are present with the respiratory failure, hypoxia and hypercapnia. See, the 50% of the patients with obstructive airway disease have airway mucus hypersecretion. So they need hospitalization, risk by 2 to 2.4 times, and frequent exacerbations by 4.15 times because of this mucus hypersecretion. So the mucus in large airways, it causes the cough and sputum production. In peripheral airways, the mucus plugs cause blocking. So there won't be any entry of the air into these things, and the people will have dyspnea. So the large airways mucus, they will have the cough and sputum production, and the peripheral airways mucus, they cause dyspnea. So the mucus hypersecretion is associated with the disease exacerbation, accelerated decline in the FEV1, and there will be inflammatory cell infiltration and lower accessibility of the inhaled medication to the peripheral airways. So now coming to the mucoregulators and antioxidant agents, the NAC reduces the risk of the exacerbations. See, if you see the WHO's list of the essential medicines, so N-acetyl-cysteine, your NAC is also one of the important essential medicine to be used as a basic health system. So N-acetyl-cysteine, otherwise called as the NAC, an appraisal in the management of respiratory disorders. It's a potent mucolytic, antioxidant, and is a precursor of the glutathione, acts as a counterbalance in the viral infections and in decreasing the inflammation and the oxidative stress. High dose NAC is reported to be effective as an antioxidant in the pneumonia, influenza, sepsis, and ARDS. So that's how the NAC will help our population. So it's a good mucolytic agent, it's a good antioxidant, and it reduces the inflammation and oxidative stress, and also helps you in the management of the pneumonias, influenza, sepsis, and ARDS. So these are the multiple clinical applications. Your respiratory medicine, COPD, or interstitial lung disease. Nowadays we are seeing a lot of the ILDs because of the rheumatoid arthritis, the lupus. So a lot of the people right now are having autoimmune diseases, and they will have the ILD. ILD people usually they present with the breathlessness, and your CT scan will definitely gives you an idea of the ILD, where you have to use the immunosuppressive drugs like azithromycin or cyclophosphamide, chlorambucil. So these are the important drugs to be used here. Your methotrexate, these all will help here. And bronchiectasis, nowadays we are not seeing much bronchiectasis because of the extensive usage of the antibiotics even in the childhood. So influenza is very, very common, lung cancer. So in all these conditions, there is a role of the NAC. So the paracetamol poisoning, there also the NAC will help you. And also in the contrast-induced nephropathy, psychiatric illnesses, neurological illnesses, and the addictive behavior. So as I told you that this N-acetyl-cysteine is an antioxidant acting outside the cell to reduce the cysteine to cysteine, which can be transported into the cell 10 times faster than the cysteine and further used in the biosynthesis of the GSH. See, these are the use of the NAC in the different lung diseases in the human. I told you that it's an antioxidant effects, anti-inflammatory, and the mucolytic effects. It reduces the clinical symptoms. So that's what we want from our patients. The symptomatic relief will be there, and it reduces severity and the number of the exacerbations. So the less hospitalizations, and it reduces the accelerated lung function deaths. So more and more early discharges. So in that way, the N-acetylcysteine will help the patient in symptomatic relief, in reducing the hospitalizations, and also speedy recovery. See, if you see the symptomatology like fever, asthenia, lack of appetite, headache, cough, etc., all will be reduced in the presence of the NAC. It's a big mucolytic agent. Effects 600 milligrams a day. It reduces the viscosity of the sputum, reduces the nature of the sputum, and severity of the cough. See the FeV1 reduction. So that is also will help you in not reducing FeV1 much fast with the usage of this N-acetylcysteine. A lot of the guidelines are there. So your Canadian guidelines or Europe guidelines, all the guidelines, they say that the treatment with N-acetylcysteine, especially the 600 milligrams, to prevent the AE COPD for patients, the acute exacerbation of the COPDs. That's how these drugs will help you a lot. So thank you very much for your patience.